Hi, everyone. Thank you for joining us today. We are about to start our webinar. The webinar's title, Addressing Diabetes Risk Factors in School-Age Children, Men Plus at Denver Health. The School-Based Health Alliance is a DC-based nonprofit and serves as the national voice for school-based healthcare. Since 1995, the School-Based Health Alliance has supported and advocated for high-quality healthcare in schools. Our focus includes policy, standards, data, and training to support and grow school-based healthcare by creating community and school partnerships. We do have a few reminders for you today. All attendees are in listen-only mode. However, we would love to hear from you. Please enter your questions into the chat box. Use the chat icon that appears at the bottom of your Zoom control panel. Also, when including your questions, please select all panelists and attendees before typing your response. Also, to turn on the closed caption, please click on the closed caption icon at the bottom of your Zoom control panel. Also, at the end of the webinar, please join us in completing an evaluation poll questions. These questions will be provided for you in a link in the chat box. Our objectives for today includes understanding the risk of prediabetes and other chronic diseases in children and how COVID-19 has exacerbated these risks. Define evidence-based strategies to improve childhood health and weight. Identifying key components of intensive family health weight programs with opportunities to implement in FQHCs as well as schools. Our presenter for today is Jessica Wallace. Jessica Wallace has been a family medicine physician assistant for 16 years. She completed her master in public health degree as well as her physician assistant training at George Washington University in Washington, D.C., and is currently a doctoral student in public health at the University of North Carolina. She has worked at Denver Health, a safety net healthcare organization in Denver, Colorado, since 2013. She believes passionately in the prevention of chronic diseases and the integration of public health innovations in primary care, and has overseen the creation of a collection of effective pediatric and adult weight management programs into the FQHC setting to help reach underserved populations. Jessica lives in Colorado with her husband, 2 kids, and 2 cute dogs. I will now turn it over to our amazing presenter, Jessica Wallace.
Oh, thank you. Give me 1 second here. Let me get the slides up. Very, very excited to be with you all today. I'm going to be talking about our MEND program. And then we'll definitely have some time at the end for questions. So please feel free to keep those in the chat so we can get to them as soon as we can. So I am going to be talking about our program called MEND Plus, which runs at Denver Health. But first, I want to start with giving a bit of background to talk through why this is important and why now. So there's a lot happening in this space nationally, even over the course of the last couple of months that I wanted to draw our attention to. Many of you have probably heard of all these things. First off, there was an update by the Centers for Disease Control to their growth charts. This was released in December of last year. And they're basically, this is meant to assist with tracking and management of children who are found to be in the greater than 95th percentile, which is equivalent to pediatric obesity. And so I've included a couple of links here that you'll have access to when we share the slide deck as well. These are great because there's some kind of frequently asked questions and things like that that you can refer to. They didn't change the actual growth charts themselves. Those continue to be kind of based on historical trends, but the idea here is that if you're looking at kiddos in that greater than 95th percentile, there's easier ways to be able to assess how people are changing over time. So that's a big change that's been happening. And of course, there's a larger context of what's happening when we're looking at weight in the United States. So this is 2020 adult data. These are the CDC obesity maps that they've been releasing for a long time. And what you notice here is different colors correspond to different rates of adult obesity prevalence by state. These are not the colors that we started out with even 20 years ago, 30 years ago. So we're definitely having higher prevalence of obesity in adults over time. And the trajectory has changed so quickly, right? And so, the idea that that this might be genetic is kind of called into question because the change is so fast. Also, the change is so great that there was this really awesome quote that I think about a lot that I've applied here, which says it is highly implausible that this pronounced trend, which is now not just in the US but being replicated in countries around the world, is simply the result of millions of independent, unconnected decisions. So it pushes against this idea that, individual people are just doing it wrong or having a hard time making the right choices. One thing that also started happening with the CDC data, just as of, I think, either 2019 or 2020, is they're starting to break this data down by race and ethnicity. So this is that same 2020 map, but looking at white Americans, and you can see the prevalence rates. And then here is the map if you're looking at people who identify as Hispanic, and you can see that there's some significant color changes happening here corresponding to higher prevalence rates. And then this is the map if you're looking strictly at Black, African, and African Americans. And so this burden of overweight and obesity is not shared equally. So it's important to aggregate the data. It's also important to disaggregate the data and really understand who might be disproportionately affected, and then use that to inform policies and resources. All of this comes back to the idea that of a social ecological model for health. And so when we're working in healthcare, we really focus it heavily on that smaller center individual orange circle there, which is the individual level. But there are lots of other layers that come into play at the interpersonal level, the organizational level, the community level, and the society level. So while we might not have the ability to make huge changes at all those levels, it is very, very important that we always keep those in mind as we're interacting with patients at the individual level. So the burden of obesity is strong and increasing over time. And we know that obesity is strongly associated with poor health outcomes. And that happens as early as the childhood years and does progress into increased risks into adulthood. A word of caution that we are going to continue to address as I move forward in this presentation is that the stigma, discrimination, and negative stereotypes are very common. And so it is up to all of us to be aware and attempting to mitigate those negative impacts. So this is just an infographic that really shows some of the complications that can appear early on in a child's life that are associated with obesity. And I think certainly endocrine disorders such as diabetes get a lot of attention, as well as cardiovascular disease, but it's not the only diseases that we see and the only systems that are impacted. So here you can see psychosocial, pulmonary manifestations, neurological impacts, gastrointestinal, renal, musculoskeletal. So really thinking about obesity as being a potential risk factor for a lot of disease pathologies. And so when we're looking specifically at type 2 diabetes and prediabetes, this is becoming increasingly prevalent in the United States among children and teens. Okay, so we know that before 1990, type 2 diabetes really was almost unknown, and it's become a growing problem. Prediabetes is rising as well, and nearly 1 in 5 youth met criteria for pediatric prediabetes. And so if you're looking at larger types of interventions tailored into high-risk areas can really address the risks for everyone. BMI trends during COVID-19. There was an article that was published in fall of 2021 that through the CDC that looked at longitudinal trends in BMI, and they tracked it from the years preceding the pandemic and then what happened during the pandemic. And what they found is that for children who were already identified as overweight or obese, the BMI more than doubled during the pandemic. So everyone gained weight in the pandemic, but that was more of an increase happened in kids who were already suffering from increased weight. And within those ranges, the kids in that 6 to 11-year-old, it had the largest increase in the rate of BMI change. So very sobering findings, but not necessarily surprising as we've been watching and all the disruption that happened. U.S. Preventative Services Task Force issued their recommendations around pediatric obesity in 2017. And when they reviewed all of the literature for this age, they recommended that clinicians screen for obesity and that we offer or refer them to comprehensive intensive behavioral interventions. What does that mean? So what they found is that lifestyle-based weight loss interventions had positive health outcomes for kiddos. And so this benefit increases with increasing contact hours. And so I'll draw your attention here to the fact that the intensivity is really one of the most important words here. And so less intensive interventions, which they actually defined the cutoff as being less than 26 hours, were less likely to be effective. So the more intensive interventions as greater than 26 hours total had strong evidence of being effective. And so that was effective on weight and also cardiometabolic outcomes like blood pressure. They did measure looking at things like quality of life and other outcomes, but those were not as universally reported as some of the other health benefits. Then, just a couple weeks ago, the American Academy of Pediatrics released their clinical practice guidelines for obesity, childhood obesity treatment. So not addressing the issue of prevention and not addressing the infants or 0 to 2, but looking at kids ages 2 and older. This has generated a ton of articles in the popular press. Not surprisingly, some of these articles have tended towards the oversimplification of the 100-page clinical practice guideline or some of the more controversial aspects of the guidelines. I highly recommend everyone read it and would love to answer any questions. We've been talking a lot about this in the circles I work in. But what I would draw your attention to and what I think relates heavily to this presentation today is that in their key action statements that they have, there is one that says that clinicians should provide or refer to intensive behavioral and lifestyle treatment. So very, very similar language to what the U.S. Preventative Services Task Force recommendation was in 2017. They have a cool little infographic they included in their guidelines, which I am showing here. And this kind of gives you a little bit of a better idea about what those, what that structure should be. So if you look here at this column called dosage, this is exactly what we were just talking about with the USPSTF. So longitudinal treatment between 3 to 12 months, and ideally with 26 or more contact hours. But here you can see this is often done patient and family together with a supportive team, that we don't delay treatment, that we really think about this and look and offer and refer these programs as soon as possible. They include education as well as support for behavioral modification and counseling. This can happen in a healthcare setting or in a community-based setting that links closely to the medical home. And then there's some areas at which the programs can be adapted. So this can be in a group setting, this can be in an individual setting, or both. And strongest evidence is for face-to-face, but there does appear to be growing evidence for virtual, thank goodness, because of COVID. So that's really reinforcing what those USPSTF guidelines are and really speak to what we're talking about today. So I'm going to move into what does this look like in practice with our experience at Denver Health. So Denver Health is a little bit of a unique system in that it is a safety net system that does include a level 1 trauma center. The hospital has been around and serving as a safety net system for over 150 years, which in Colorado time is a lot. We also, though, have a network of federally qualified health centers, which is the world I work in, and we have school-based health centers as well. So we are an integrated system, but what I'm going to be talking about today really speaks about the FQHC side of things. We've had our own COVID impact, which we've been able to track and measure. And this is, there's lots of different ways to show this data, but we found this particularly compelling. So when you look at the percent of our kiddos who were at a healthy weight in January 2020 before the pandemic started, this was about 50%. And then by September 2021, you can see that dropped to below 55%. So that's demonstrated here in this green graph below. And you can see we weren't killing it even before, certainly, but the degree of the drop that we saw as an impact of the pandemic is something that we've never seen before. And, if you look at adults, just if you were curious, it's even worse. Sobering for sure, and I think speaks to the need that there is. The other thing that we've done, and this is past data when we were doing chart reviews, but we looked at our roughly 22,000 kiddos in our system who are overweight and obese. And even though we're in a relatively healthy state based on those CDC maps, because of the nature of FQHCs and the patients we serve, those rates are actually significantly higher at 36%. We looked at to see what kinds of metabolic abnormalities might be present. And so when we did a chart review of those kiddos, for the ones that had been screened for diabetes and prediabetes, levels were about 50%. That was a shock for all of us. We didn't really, we had never seen the data that way, and it was very sobering. Also, 14% had elevated cholesterol levels, 12% were found to have an elevated ALT, and 22% were found to have elevated blood pressure. And so this doesn't manifest as fevers, right? So chronic diseases, that's part of their, the silent nature of them until they've progressed significantly is one of the things that makes them so dangerous. So this was quite compelling for our organization to think about taking action. And so I do want to pause here and make sure that we go over the fact that obesity is not a one-to-one correlate with disease, right? So we showed data earlier that yes, obesity is strongly associated with disease, but it's not 100%. And so a lot of this data that I'm going to show in the next couple slides are based on adults, but you can easily kind of extrapolate out to kids. So looking first at the left-hand side of the screen, if you look at adults who are found to have an elevated BMI, 2/3 of those are also found to have metabolic abnormalities, which of course is that ultimate health risk. But in that light blue triangle right here, that means that fully 1 in 3 of those adults with elevated BMI are metabolically normal, sometimes called metabolically healthy obesity. If you look on the other side, adults with a normal BMI, 1 out of 3 of those have metabolic abnormalities right here in this dark blue. So you can see that if we're looking to reduce health risk and we use obesity as the sole criteria for either enrolling or not enrolling people in programs, that we are not going to be hitting all of the people who might really benefit from making behavioral changes to reduce metabolic risk. Another compelling study that was done, again, with adults was an NHANES study with almost 12,000 Americans, and it was just published back in 2012. Bear with me here to talk through the slide because I think it's really powerful. So they looked at, out of all of these Americans, who of them were participating in these 4 major healthy habits. So do you eat 5 or more fruits or vegetables a day? And spoiler alert, the vast majority of us do not, regardless of how much we weigh. Exercising regularly, drinking alcohol in moderation, and not smoking. And so if you look here at the graph where it says habit 0, so for people who don't do any of these 4 healthy habits, what you find is that the darker the box, which corresponds to a higher BMI, the more you weigh, the more likely you are to have a risk of mortality, increased mortality and morbidity, right? So BMI really matters. If we move across on the x-axis here over to habits, by the time you get to really even 2 or more habits, meaning these participating in these healthy habits identified, BMI no longer makes any difference in terms of your health risk. And so that's important to notice because it talks about nuance, right? And if we're looking at keeping people healthy and reducing their health risk, yes, we're talking about BMI, but we are also really talking about those underlying health habits, irregardless of what BMI does. So again, it's important to note that obesity and disease are not a one-to-one relationship, but there is a lot of data to show that structured lifestyle change programs can make a big difference in reducing those health risks. So a lot of the original data to evidence-based was a CDC structured program called the Diabetes Prevention Program, or DPP, and they focused specifically on adults with prediabetes, estimated to be about 85 million people. Most of them are unaware, again, looking at the chronic nature of disease. And so what they found in years of this program is that for patients who were able to lose 5 to 7% of their body weight, so if you weigh 200 pounds, a loss, let's say, of 10 pounds, that you were 58% less likely to develop diabetes. So we do know that small amounts of weight loss, and especially the underlying lifestyle changes, can absolutely work to reduce your risk of chronic disease. So what we've done in interpreting all of that data at Denver Health is to say that, we're really going to try and move away from this idea of a number on the scale and kind of these very strict weight loss recommendations into, especially for kids, how do we make sure that you're healthy and happy and living your best life? And so we, within our programs, have created this AIM statement that I just wanted to share because we really love it and it feels very positive and empowering for us as a team. So we're here to support patients in making lifestyle choices that help them manage their chronic conditions, improve the quality of their life, and reduce their health risks. And we do that by supporting them in mindfully enjoying delicious and healthy food, moving their bodies in ways that make them feel happy, and improving their self-confidence, happiness, and well-being. So that then takes us to our MEND program, which is one of the elements of our Healthy World department that we offered. And so MEND stands for Mind, Exercise, Nutrition, Do It. And it is a family-centered group intervention tailored for kids in the school age range. And it is compliant with those USPSTF guidelines for an intensive intervention. So families meet usually twice a week for 10 weeks for 2 hours each session. And this is the general breakdown of how those classes occur. So the first hour is focusing on that mind and nutrition piece with kids and adults together. And then in the second hour, there's a more in-depth parenting discussion, and kids go on and do healthy, non-competitive play-based games. It's an outside of the box program. So if you are out there and you've got some access to some grant funding, it's a really great way to train up staff in program delivery and then get these kits that really have all the materials and stuff that you might need. MEND is not the only curriculum out there. They all have similar components, but MEND is the one that we originally had grant funding for through a Kaiser grant and also our state Health Foundation. So that was where we originally got our grant funding for to do MEND. And so one of the things that made MEND as a program compelling to us is that there was a randomized controlled trial that was done in the UK in 2010. And what they saw here, don't worry about the details, but they did show statistically significant changes in BMI and in waist circumference and in physical fitness over time, 3 months, 6 months, and sustained at 12 months, which is not shown here. And that's compared to controls. I think another cool thing to notice is that while kids were referred and participated in this intensive intervention because of their weight, their self-esteem score went up over time. So, that is really, really positive. And they were very deliberate in creating the curriculum to make sure that there were pediatric psychologists who were involved in that to make sure that that happened. So, don't have to reinvent the wheel. There are programs out there that have been proven to work. And then they did also further dissemination studies that looked at implementing the program in communities in the US that were tended towards lower socioeconomic status and higher percent of public insurance or uninsured. And so that also showed positive trends. So all of that really fed into our decision to implement MEND. We decided to bring it in-house. So it had been offered intermittently in different community settings, but we weren't having much luck getting our families in there. So when we got the grant, we decided to trial running this intensive program within our health centers. So here you can see the 3 different health centers that we decided to implement MEND in. They're all in very different parts of Denver with different patient populations. You can see some of the clinics are quite old, and then one of them was brand new at the time. And if you're working in a school-based health center or in a school setting, you can definitely bring these kind of curriculums into there too. So I'm talking about our FQHC experience, but again, if you have school-based health centers or schools, there's plenty of opportunities to do the same and have the same learning we did. So for the first 2 years when we had grant funding, we were really rigorous about measuring all the things. And what we found is that, yes, even implementing it in a very different setting, we were still able to have strong positive impacts on kiddos' behaviors and also on health outcomes, such as weight and waist circumference and that physical fitness. And the physical fitness test, which is this heart rate recovery test right here, was strongly significant. So even though we did not have a gym, right, we're exercising in waiting rooms and conference rooms and outside in parking lots, kids were still becoming more physically fit with that. Then we, over time, have created a lot of different adaptations. One of the main ones that I think it's important to bring up is the integration of provider medical visits, what we've since kind of been branding as MEND Plus. And so for our rationale here, we really use the group visit model and specifically centering pregnancy model for those of you who might be offering that in your setting and the Centering Healthcare Institute. And our primary goal was to improve our evaluation and management of individual issues. So if you think back to that slide we saw where we really realized how prevalent things like prediabetes were and stuff like that, we knew that we could do better on lab screening. We knew we could do better about the workup when things were found, and also, the individualized plan and follow-up. And that's not something that the group can handle, right? We also knew that, the strength of FQHCs is that we have wraparound services. So there were absolutely behavioral health and social work issues that were coming up with our patients and families in the course of these groups, and we could connect them to the resources and support that they needed there too. Cynically speaking, that also gave us an opportunity to have some sustainability with some revenue generation to offset the program costs long term. Then in 2018, I believe the CDC came out and helped us measure the MEND program in a different way. And don't worry about the specifics here, but basically what they did was they looked at kids who had ever participated in MEND over time, and they were able to pull from data from before they ever participated and longitudinally after they were done. And these kids were kids who their change in percent BMI, as well as their change in systolic and diastolic blood pressure, were going up and up and up over time by a certain, estimated amount over time every month. And then by the time they had participated in their first MEND visit and then continued even after they were done, that trajectory changed completely. So kiddos ultimately lost weight and their blood pressure started to come down. So that was really cool data and we were able to compare it to controls in our system. And that when you're speaking about the organization continuing to support and invest in these kind of programs, this is absolutely the kind of thing that they want to see, right? That it is worth it to keep offering these kind of programs because we're seeing the health impacts on our patients. If you look specifically at diabetes risk, the CDC wasn't able to analyze this as rigorously as they wanted because we weren't drawing blood on every single kid that was coming in. So this is just me on the backside looking at diabetes risk and what happened with our MEND kiddos. And so this is more like kind of a quality improvement kind of thing, but I did want to share with you, at the time when I looked at the data, we were screening, we still had plenty of opportunities to screen better. We were screening about 44% of kids. Out of those, 39% actually were found to have that pre-diabetes range lab. A lot of those kids were never rechecked, and that's not rescreening, right? We found an abnormal lab. The treatment was this intensive intervention. We didn't ever follow up. And so there are plenty of opportunities for improvement in this care cascade. But out of the ones that we had were identified as pre-diabetics, and then they had a follow-up later, what we found here is that 61% of them improved. So, nothing is 100%, but certainly for kiddos not taking medications and looking at their long-term health risks, this was encouraging signs. Then a couple years ago, I got involved in a project that really is about disseminating and implementing our experiences and lessons learned with the MEND Plus program into other FQHCs. So this is via the National Association of Community Health Centers, and it's a grant called COMMIT, which stands for Childhood Obesity Management Models in Team Setting. And here you can see we work with different FQHCs in not just Colorado, but also Arizona, Illinois, North Carolina, Florida, and Mississippi. And, that's been an interesting experience over the last couple of years, in part because of COVID, but also because, what we had to do was take that MEND curriculum and really kind of push along the edges in order to adapt it to make it work. And that makes intuitive sense, I'm sure, to a lot of you on the phone, right? What works in Colorado is not going to necessarily work where you are. And as we were dealing with this with the different teams, what works in, urban Miami is not going to work in rural Mississippi. And so it was important for us to think through how to make sure that we maintained the key components, making sure we maintain the intensity, but importantly, allowing and celebrating the innovation and adaptation that was happening at the local level. So that's been a project that's been ongoing. And then COVID happened. And so COVID really, forced, for safety reasons, the shutdown of all of our in-person group programs in order to keep our patients safe. And so, there were a lot of families who were really engaged in this work. And then certainly, as we know from the data on the pandemic and its impact, in some ways, the struggles were exacerbated. And so what were we able to do? We really took the opportunity to do the next right thing and try to pivot to a virtual option. And so what that looked for us was transitioning all of the materials from these kind of in-person, very dynamic, facilitated group discussions into PowerPoints that could be done on Zoom. And so, our team really worked very hard to make this material available and still keep that interactive nature of the Zoom meetings. That was extra hard for exercise, but we found a whole lot of amazing free stuff that was available online. So we shared this information early and often with our families. When we were in class, we did some of these videos together, and people could turn on their screens or turn them off and do the exercise together. So, trying to do the best that we could in that setting. The other adaptations that we made were really, again, about knowing what our families were going through. So for nutrition education, we added in cooking demonstrations. These were all virtual, but we were able to distribute food. So we families got bags of groceries, and then everyone kind of joins in online at home and is cooking together. And that's been something that's been super awesome to do, and families loved it. We also knew about the intensive stress that was happening, so we've added behavioral health more deliberately into our model and into the support that we offer for families. So I do want to pivot here as we're looking at our experience in the MEND program and just be really transparent with you all about where we currently stand as we try to reconcile what we know about weight stigma and both internalized and externalized weight stigma. And so I share this growth chart of a real patient who is participating in our program. And, this, for all intents and purposes, was a success story for us. We would print out growth charts and hang them on our, walls next to our computers, right? So in 1 year, this is an example of a girl whose BMI went from obese, kind of slowly down in that year into the overweight category and then into the normal category. But then there were a lot of other exam findings that popped up that were concerning. And ultimately, she was diagnosed with an eating disorder. And so I think that, examples like this, sometimes not quite so dramatic, have really led us to try to think very, very deliberately about how often do we miss or even praise disordered eating in patients because their BMI is, quote, improving. Here's another example, right? And again, this is just something we've used to really challenge our definitions of success. So here's another girl who was participating as she came to our programs. This was February. Her BMI percentile was 98th percentile. She was actually found to be diabetic. Her A1C was 7.5%. 8 months later, her BMI is 32. So now it's at the 98.5th percentile. And you can see here, if we talk about how the CDC growth charts have changed, you can see how this becomes very messy to evaluate like what's happening for this kid. And the new growth charts would make that a lot easier. But either way, the percentile did not improve. Her A1C dropped to 6.1%. So what happened here? She didn't lose any weight. She didn't take any medications at all for diabetes. We got her improved food access. Family was identified as having significant food insecurity. So we have a program, community partnership through Denver Food Rescue. We were able to get the family connected to food and healthy food resources. She started participating in Mend with her family, and they really loved Mend. They did a lot. They really engaged with the thing with the program as a family. She got really into skateboarding. She started loving skateboarding and developed a lot of self-confidence and pride around what she was doing there. And so I think this is an example of there was no weight loss. There was no meaningful change in her weight and BMI, but no one would doubt the impact that this has had on her as an individual. And so we are trying to be very, very deliberate about expanding our definitions of success and what we praise, and working to make sure that we define what success means jointly with our patients. And so here is just a random list of some of the things that patients have chosen to focus on over time. Improvements in labs is a big one, right? So if we are trying to do better about completing the recommended screening guidelines, that can be very motivating when a parent in particular realizes that their kid has abnormalities that place them at risk. So celebrating when those improve, because you can't fake those. You have to put in the work in order to see the change. Changes in energy levels, right? That is something that's highly motivating for people. Having a sense of mood stability, right? As they get more control over their diet and over their physical activity levels. Their physical abilities, right? Now I can run more. Now I can play the way I want to play. I'm excited to be riding my bike or to be skateboarding. I'm sleeping better, right? Sleep is a huge one. And we know the complicated interplay that has around weight. Having regular bowel movements is highly motivating for people and speaks to the diet changes. Improvement in stress, that is huge, right? A lot of folks and kids for sure are feeling this in their day-to-day. And so oftentimes this is a really important marker of success for them. Increased strength and endurance, increased confidence and sense of self-efficacy. And so I think, again, this is not an exhaustive list, but it's been very, very helpful for us as we're working with patients in these different programs to help define with them what they really mean. And the first time around, they might say, I want to lose weight, or I want to weigh this much, or I want to look like this person, or look like I did back then. And really, not negating that as a priority for them, but also trying to say, what would that mean for you? And how do we define success in lots of other ways? And so what I would say in closing, before we open it up for questions, is that, this is not rocket science. It really isn't. But it is hard, and it is hard to implement in our settings. And because of the way we don't often have the resources that it would really take. So one of the things that I thought was kind of cool that the AAP included in their guidelines is, yes, they are trying to get more and more folks to do these intensive interventions, right? And so it says, still attempt to deliver the best available intensive treatment to all children who qualify, right? And so, let's be intentional collectively about how do we get more of these programs available. And I think, part of the guidelines will help hopefully then draw the opportunities for increased funding down the road. Where those programs are not available, and in-house, how can we best build collaborations with other specialists and programs in the communities? And that's going to look different regardless of where you are. And so, it's kind of about building that plane as we fly it. So we know we do have strong evidence that shows what will help, but also when that doesn't exist, how do we continue to work towards doing the best that we can? And so there is always something, sometimes small, that can be done. And so that's what I'd love to kind of open it up to for you all to think through, and also answer any questions you have about our program. I am grateful for the work that you do. Times are tough. They continue to be tough. So my primary hope is that this feels exciting to hear about, and does not and something that might spark a little bit, but not feel like, oh no, there's more we need to do, because you're already doing all the things. And I've got some references here that you'll get in the slide deck as well. So let me stop sharing and we can open it up. I went through those kind of fast.
Yes, but it was awesome. Thank you so much, Jessica. So yes, right now we want to give everyone an opportunity to enter their questions into the chat box. And while we give you guys a few moments, we're just going to have a couple of announcements just while you're entering your questions and putting your thoughts together for Jessica. So our first announcement is that our conference is coming up this year. We're finally in person, June 26th through the 29th. At American University. So we have 6 different categories, and also including our Be the Change Youth Training Program. So we would definitely like to welcome all of you. Please save the date. We do plan to open registration up around March. So please look out for that. Register for our listserv if you want any updates. We send those out bi-weekly. So please, once again, save the date for our upcoming conference. And also we will have our next webinar, Addressing Diabetes, on March 30th at 2 p.m. Eastern with Mary Savoye. Participants will learn about Yale's evidence-based pediatric obesity and Bright Bodies healthy lifestyle programs, and explore potential resources and takeaways to support school-age children obesity prevention and treatment. So we definitely recommend you guys going to our site, going to our events page, and you can see there more about conference information and our upcoming webinars. All right, so now we, as everyone is entering their questions, so do we have any questions to announce, Shamika?
Not at the moment.
I'll do a quick plug for the other upcoming webinar. The Bright Bodies program is really amazing and has some awesome evidence, and the same kind of history around kind of tailoring to where it's being offered. So definitely tune into that if you can.
That is great. Thank you so much, Jessica. And also, so of course you just gave us so much information. And also, if you do have questions, you can also still email us later if those questions kind of come to you later, and we'll just connect with Jessica. But we still have a few extra minutes for you guys to put those questions in there. And I'll let you know that we will be sharing the slides and the recording to this webinar in 2 to 3 business days. And once again, that will also be on our events page that we have all of our information about upcoming webinars.
And while we're waiting for questions too, I would love to hear anyone who feels like sharing if they've had a chance to look at the AAP guidelines, or if they've heard anything about it, or anything they want to share too, because I feel like that's generated a lot of significant conversation of late.
Yes, and you can also maybe put your name into the chat box, and we can allow you to speak. If it's like a lot of information, too much to include in the chat box, please let us know and we will unmute you.
Mhm.
Yes, we do have a question. The question asks, at which points do you integrate health visits into the MEN program? Is there a structured schedule or as needed?
Excellent question. And I didn't speak on that, so thanks. Yeah, so we've done a lot of different things over the years. What we've settled, and I can speak to other health systems that have done things a little bit different, but we've ultimately settled on the potential for once a week of a medical visit. So MEND meets up to twice a week, but we on one of those days, we will have some sort of a provider there, a medical provider or behavioral health provider. And then the way it works is that similar to the centering pregnancy model, there's a group happening, and then patients are kind of pulled out one at a time for an individual medical visit. And that's where we go over their individualized nutrition and physical activity history and kind of health behaviors and challenges. And we do the individualized assessment and plan. Those are meant to be pretty brief, but we utilize some motivational interviewing. Certainly if they've had the lab screening or not, we order the test. We go over the results. If they're, for example, if a kiddo is found to have elevated ALT is likely a marker of fatty liver, then we talk about individualized goal setting and education and recommendations that would help improve that and reduce that risk over time. Then they go back and they join the group again. And so those visits, you can make a lot of progress in, these kind of brief visits over time while they're also getting the really intensive support of the group. So that's what we've found to be most successful. And but there's other models as well. Some people will do a provider visit at the very first visit because there's kind of that initial intake, and then one at graduation. So that's another way. But really, the job then of the provider is not to reinvent the wheel, because they're getting so much information and support in the group, but really just address the issues that can't be adequately taken care of in the group setting. Oh yeah, chat is disabled. Okay, let's get that taken care of. Thank you for letting us know.
And if you may have any questions, you may also enter your questions in the Q&A box. Thank you. And we do have another question. The question is, do you have a program coordinator that runs points on these events, or is it a community member liaison?
Yes, staffing. Oh gosh, we've done all the things. When we first started, because we were grant funded, and because, we looked at kind of our healthcare teams and we're like, oh, nobody's a nutrition leader, nobody's an exercise leader. And so we hired people from outside the organization for, a very limited number of hours in the evenings. And that worked okay. But what we found over time is that it actually has been really helpful to just train up our existing staff. And they just kind of diversify their roles a little bit. So, certainly we do have the medical provider and behavioral health provider integration now, but, for folks who actually run the program in terms of the nutrition leader and the exercise leader, we utilize medical assistants, our receptionists. We have navigator type people, which is, I think, a little bit similar to like what y'all might use for community health workers. Occasionally you've used nurses, really anyone who has an interest in, kind of doing something a little different. And, sometimes people want extra hours and extra pay. And so having, being able to work their MA shift and then, come down and do MEND in the evening hours for a couple hours has been great. We do have now, because we're so big, because we run MEND in 3 clinics, and then we have another like multidisciplinary team. So we do have like a coordinator level person who has, kind of slowly increased the amount of her time that she's been given to oversee these programs too. Excellent question. It is a lot to coordinate. It just is. And it's not the nature of how we do primary care usually. So that's where I think, the rocket science piece comes in, is like, we have one way of taking care of patients. And so when you start to look at evenings and groups and, kind of giving the more intensive support, you do have to have a way to kind of invest in your team to do that. What I will say from all of the different types of team members that we've used over the years and stuff is that we're definitely, like, across the board, people do this and have fun doing it as staff, right? And so when you're looking at the intense pressure that we're all under in healthcare these days, yes, there is a piece of this that is something extra, but I would say that the rewards that we all get from doing a program like this keep us around and keep us motivated. You get to know your patients on a very different level and see how they interact as a family unit, see how they interact as a community. You build community, you take away some of the hierarchy of medicine. It feels very positive and fun. So it's been nice to be able to, have these opportunities for our own coworkers to do the work.
Thank you, Jessica. We also have another question. It says, in Puerto Rico, we have school-based services with a pediatrician and nurses. We find many cases of obesity in rural areas challenges and are very related with parents to engage.
Mm-hmm. Mm-hmm. Yeah, there is no perfect solution on this. I think if you look at the research of all these programs, MEND, Bright Buddies, whatever people have come up with, oftentimes they do work better in urban areas where you have, the health center or in the school and stuff closer to where people live. But things change, right? I mean, even in Denver, we've got so much gentrification happening, and where people are being pushed into in order to maintain affordable housing, you don't have this health center, close to where everyone is anymore. And so, but rural areas struggle more. And I think that's where some of these opportunities, either virtual models or hybrid models, can really help. When you're looking at virtual models, one thing I will just acknowledge is that it's harder to engage parents. The kids will get engaged and play, but it's harder to have both. And so the best success we've had with that is, either doing a separate little virtual meeting for parents or having breakout rooms with just the parents. And also we've started to do things like creating, Facebook groups and WhatsApp chats and things like that, where parents can engage in a way that works for them. But I hear you, it is hard.
Thank you, Jessica, and thank you for your questions. I believe that is the last question that we have right now.
Okay.
So thank you very much again to our presenter, Jessica Wallace. We are grateful for your presentation today and have learned a lot. So we thank you. At this time in the chat box, you should receive a link to view the evaluation for today's webinar. If you would please take a few minutes to complete the webinar, we will greatly appreciate it. And again, the slides and presentation will be available on the School-Based Health Alliance website within 2 to 3 business days. We thank you for your time, and we are glad that you were able to join us today. Thank you and have a good day.
Thank you. Appreciate it, guys.